Drew, I think, please. Are we good to go? Okay, great, thank you. Good morning, everybody, and welcome to the Governing Body public meeting for the 29th of July. We've got a number of apologies this morning, which I guess is a sign of the time of year. So we've got apologies from Simon Tapley, Glynis Atherton, Sheila McCormack, Steve Brown, Ruth Harrell. Charlotte Burrows needs to leave no later than 1. Darren Alcorn has Susan Masters deputising for him, and Sheila Roberts is also apologising. We've then got some additional attendees. You're very welcome, all of you. So we've got Nina Parnell and Darren Halifax here to do our patient story this morning, which is regarding volunteering and community support and the Neighbourhood Friends West Bank scheme, which is really good to hear about. Wilkinson is deputising for Sheila Roberts on the pre-COVID presentation. And we've had a request to take Al first because Al has to chair the silver call this morning at 11. So if it's okay with everyone, I'll take the pre-COVID report at 10:15 and then move on to Andrew's report thereafter. Okay, thanks very much. So does anyone have any new declarations of interest before we start the meeting? No? Okay, in which case we'll start as we usually do then with our patient experience story, which is from, as I said, Nina Parnell, who is Head of Volunteering and Community Support for the Neighbourhood Friends scheme in West Bank. So Darren, do you want to say anything by way of introduction for Nina?
Yeah, thanks, Nicholas. Hi, to introduce you to Nina Parnell. I said Nina is the Neighbourhood Friends lead at West Bank, Exeter, the award-winning programme around volunteering and discharge from hospital. So I'll pass you on to Nina, who can tell you all about it.
Okay, great, thanks.
Thank you, Darren and Nicholas. It's a pleasure to be invited this morning to share the success story of Neighbourhood Friends. It's been an interesting journey which has led to the development of a service which we are so incredibly proud of. Our journey started in the summer of 2014 when West Bank, along with 7 other organisations across the country, received funding from the Cabinet Office and NHS England to pilot a social action programme which aimed to better support people over the age of 75 and to reduce pressure on hospitals. The service was available for people living in Exeter and Budleigh-Salterton and had 2 streams of work. The rapid response stream of work provided a volunteer-led service which offered one-off or short-term support for people as they were discharged from hospital or to prevent an admission into hospital. So, for example, people coming out of hospital, a volunteer would collect them, take them home, help to settle them back into the house, turn the heating on, check all was well in their fridge, do some shopping, whatever that was needed to be done, and in very practical terms. To prevent someone being admitted into the hospital, volunteers, the service worked alongside services like the urgent community response, where if they were having a hospital bed and the bed, a bed need to be moved to make way for that or a piece of equipment, our volunteers would go into the property, move the bed to make way for the equipment, or we'd fit a key safe to help to enable the community teams to get in. The other stream of the service was for the longer term support, which was aimed at reducing social isolation and loneliness, where we provide traditional roles such as befriending or supported people to join a local activity, or for those people that fell short of needing a formalised package of care, we helped to link them into like home help type services to help with practical housekeeping tasks. Our targets for the first 6 months were very ambitious. We needed to recruit 120 volunteers and deliver 600 referrals. 120 volunteers to recruit in 6 months is a very big ask. So we took a fresh approach to our volunteer recruitment. We recognised that a lot of people actually want to volunteer, but they work, so which makes it very difficult to give a weekly or a regular commitment. So we created a home from hospital role, which was a very flexible role, that it meant that people could dip in and out of it as their work pattern or their work-life pattern suited. We also reached out to medical students, as we thought it would be an interesting role for them as they went through their studies. And of course, we went through the more traditional routes of retired people. Well, it turned our demographic, our volunteering demographics, absolutely on its head. At the end of it, we exceeded the 120 volunteers, and a large percentage of those were actually working age or younger people, and mainly men as well, which was really interesting because traditionally we attract older ladies into the volunteering roles that we offer. So generating referrals for any new service is difficult, but with such a short sell-by date of just 6 months, we were really up against it. However, we developed some really good working relationships with our colleagues at the RD&E, which still stands firm today. We started off working with patients who were being discharged from the then rehabilitation ward on Yelm. And we worked really well with the occupational therapists on that ward, who of course rotate around the hospital. So they share stories, telling colleagues about this great service where they were being supported. So we were really on our way, and we achieved all of our targets within the first 6 months. The success of our project triggered 2 follow-on grants from the Department of Culture, Media and Sport. Oh, that's a bit of a mouthful, isn't it? And part of those grants were to extend our reach to include all adults over the age of 18 and the full geographical footprint of the RD&E. We then went on to receive subsequent grants from Devon County Council and the CCG via the Improve Better Care Fund, which has supported the delivery of the service to date, and our current grant goes on until the end of March next year. With the implementation of social prescribing services across the localities, our delivery specification was reduced just to provide the rapid response stream of work in 2018. The scale of our service has now reached that we deal with 2,200 referrals per year, which are made by professional health and social care staff via our help desk. I'm so sorry. Whoopee. I should have unplugged that, I'm sorry. So where was I? 2,200 referrals per year, which are made by professional health and social care staff via our help desk. 99% of all referrals are made by telephone, and about 90% of them request a same-day service. The majority of the referrals are to assist with a discharge, with about 1,500 referrals a year requesting that service. And 18% of those referrals we deal with within a 1-hour time frame. So that's from receiving the call onto the help desk to getting a volunteer to the hospital to collect the patient, which is pretty impressive. The geographical split for the area is roughly that 40% of referrals are for the Exeter area, 35% for East Devon, and 20% for Mid Devon, and the rest are out of area. We have a small and very dedicated team of staff of just 3 who manage 150 volunteers who between them give 5,000 hours of their time and drive in excess of 55,000 miles per year. Their efforts have been recognised with a number of awards over the 7 years, include a bronze and silver award from the Devon and Cornwall Outstanding Care Award, and one of our volunteers won the Pride of Devon Volunteer of the Year Award. The service has earned the reputation as a can-do service, which was really put to the test during COVID. I was genuinely concerned about how we would continue to deliver the service, because obviously a number of our volunteers have their own health issues or are over the age of 70 and would have to isolate. Well, I really didn't have to worry. Our volunteers were just amazing. They just, at a time when a lot of people were avoiding the hospital, they just kept going. And we were also joined by a lot of new community supporters, people who've been furloughed or so we had taxi drivers collecting patients from the RD&E, draymen moving beds for us. It was absolutely incredible. It was just brilliant. And with just 56 volunteers, we actually supported 2010 referrals during that period. It was, as I say, incredible. During the first lockdown, we received a request from one of the OTs at the hospital to see if we could go and collect glasses, of a gentleman who had been admitted overnight, was extremely anxious and was really not settling well onto the ward because he couldn't see properly. And was there any chance that a volunteer could go and collect the glasses and take them in along with his walking frame, which he'd left? Which we of course did, and we turned that around within 2 hours. Now the referrer was so impressed that in the middle of this pandemic, she could pick up a phone to a volunteer who would go and collect someone's glasses. A really simple thing, but it made a massive difference that she nominated us along with her colleagues at the hospital for the Queen's Award for volunteering. I was incredibly proud to receive the nomination of the award in May. It was just such a special recognition, and our volunteers so richly deserve that. That I can give you so many case examples and case studies of where they went above and beyond, but for me, this one probably sums it up. We received a referral from Devon Partnership Trust from a support worker who was supporting a lady with mental health difficulties who had become bereaved. And she was really, really struggling and needed to be with her family, who lived 400 or 200 and odd miles away and had absolutely no way of getting there. Was there any chance our volunteers could take her? Of course there was. We've got a partner, a husband and wife couple who volunteer for us. They volunteered their time. They drove the lady. They completed a 421-mile trip to take the lady to reunite her with her family. It doesn't get any better than that. And that, for me, sums up the service. We're such a can-do service. And as I say, our volunteers so richly deserve that award. That kind of brings me to the end of a very whistle-stop tour of the Neighbourhood Friends Service, because I know that you've got lots to talk about this morning. So I'd like to leave you with this thought. Neighbourhood Friends is all of our success. It's not just West Banks. It demonstrates partnership working at its absolute very best. And as we move in towards integrated care services, if you want an example of what works well, this is it. Absolutely. I've delivered a lot of projects over the years, and I can honestly, hand on heart, say this is the best. It works. Not only does it improve patient flow through the hospital, it generates extra time for staff on the wards because they don't have to spend lots of time making phone calls to try and get a patient discharged. One phone call sorts it. And obviously it creates volunteering opportunities, and it also improves the patient's journey. They so appreciate being supported on their onward journey, and I'm sure that it helps with their recovery. Also, the service was it really difficult to quantify the savings that we're making for the system? It goes without saying that we earn our keep. And as I say, and long may it continue. So there we have Neighbourhood Friends, an absolute success story. And I'm very, very happy to take any questions for anybody who has them.
Thanks, Nina. Susie?
Nina, first of all, I just want to say a huge thank you. I'm blown away by this. It's volunteering at its absolute best, just completely wonderful. My question is, I seem to remember a few months ago, the Red Cross was, there was discussions about bringing the Red Cross in instead to do this. I can't remember whether it's to replace or whatever, but I seem to remember it being a very clumsy bit of sort of national commissioning, which cut directly across all the great work that you're doing. Can you tell us what happened there?
Yeah, of course. I think what happened was, my understanding is that NHS England provided some funding nationally to improve, just better support the hospitals through the winter period, and that the funding went to the nationally to the Red Cross, without thoughtful actually that the services, probably not just in Devon, were successfully being delivered by other partners. So yeah, it would have been good if it been recognised that our service was already delivering it, but in the spirit of good partnership working, we offered to support and work with the Red Cross in any way that we could. And you know, probably at the time over the winter, there was enough work for both of us anyway. But my understanding is that that funding has now stopped.
Okay, and you've been there all the time, keeping going.
Yes.
Thank you very much indeed. I did take this up at the time with the NHSE Commissioner nationally. Complained about it. Thank you.
Okay. Thanks, Susie. John Walmsley.
Thank you, Nina. So that's a very inspiring story and restores my faith in human nature. And it's more than partnership working at its best. I think it sounds like it's society working at its very best.
Absolutely.
But what it does need is a little bit of help just to sort of bring it all together. And I think you said you had 3 full-time workers. So my question, Nina, is, and you sort of implied there's a slight cliff edge for the end of next year, for the end of March next year. How will you fund the 3 core workers for next year? Do you feel you have good support from the partners, the sort of statutory partners? So I'm interested in how you fund that, because I chair One Northern Devon, and we have a similar scheme. We would aspire to what you've achieved, Nina. So I'm inspired by this. So how do you fund it? How will you fund it?
So we have got a really excellent working relationship with Becky Harty, who commissions the service on behalf of the Eastern area. I'm working alongside Lee Baxter, who's one of the assistant social directors of social services, I understand. And they're working with us now to look at ways that we may be able to get the service commissioned, because, as you said, we've been going along a bit hand to mouth for the last 7 years, and we've been at times down to a month to go and not knowing, whether we can continue to employ the staff.
Okay.
But I, as I said, working relationships with Becky Harty are absolutely brilliant. She's so supportive of the service, as is Darren. So I'm hopeful that we'll go forward.
So that phrase hand to mouth, and I'm sorry to hear that, because that's a very stressful thing to have to go through, to not know quite how you keep such an award-winning service going. So I think there's a message there for all our partners in this health and care system to acknowledge the good work. So thank you, Nina.
Thank you. Simon Kerr and then Andrew Millwood.
Yeah, thanks, Nina, very much. And I'm an East Devon GP, if you don't know me. We very much appreciate in primary care all the contributions that the voluntary sector make in all the various different ways. Neighbourhood Friends I'm very familiar with. Ottery Help Scheme, great service. Trip in Honiton, great service. And we try to support, certainly in our practice, we try to support our local legal friends financially, both particularly annually, but also in the recent work they've done with us supporting the COVID vaccination programme. What I was thinking, though, is how do we get you visible, a bit more visible to the wider community? And we're working quite hard to improve access in our practice. We've had some criticism, sadly, recently because of all the challenges that in terms of our access. We're looking at telephone systems. We hate the thought of it, but press 1 for doctor's appointment, press 2 for nurse, press 3 for prescription. I'm just wondering if we had press 4 for voluntary services support or neighbourhood friends support, that might actually meet the needs of quite a lot of people who ring us for all sorts of things. And I just wonder how you would feel about being part of that in Exeter, perhaps, and in Budley, if that was something that the primary care people were interested in.
We'd be absolutely delighted to explore that possibility. I'm very aware of Emily at Ottery Help Scheme, because when we stopped our longer term service, what we've done is we signpost. So where we identify a patient needing onward support, we refer into the local services. So we often refer into Ottery Help Scheme, for example, if a patient needs help with shopping or what have you. And we do support out in the areas for example, people that need to go back to hospital for an X-ray or something following their stay. If the local help scheme's unable to help, then they can make a referral into us, and we will use one of our volunteers to do that trip. So
I just think our real opportunity to get you really more integrated with what we're doing on a day-to-day basis, and 100 calls that come in every day, 150 calls, maybe 15 of them might well be able to be supported if we got you more involved in the sort of triaging process.
Very happy to explore that opportunity.
Thanks, Nick.
Okay, thank you. I've got Charlotte, and then Andrew, and then Joe Terrell.
Hi Nina, thanks for sharing. It's incredibly reassuring to hear the work that you're doing. My question was, have you been asked by others either in the county or out to share some of your learning ways of doing things as a kind of model of a service? And equally, do you sort of look elsewhere to sort of how you can continue to develop and improve your service by what others are doing?
Interesting, and we haven't been asked by anybody local within Devon. My sister-in-law, who works in Burnley, is very interested in the service, I've got to say, but no, we haven't. We're very happy to share our blueprint of our service with anybody, and if we can help to develop the service in any way, then obviously we would be happy to do so. No, we haven't been approached to ask to deliver it anywhere else as yet.
Okay, thanks. And Andrew?
Yeah, firstly, thank you, Nina, for highlighting the fantastic work you do. I guess it shows what wonderful work thousands of volunteers do every day across the country, which is fantastic. My question is not to you actually, but is to Susie really, which might seem odd, but it isn't. It picks up the funding issue that you and Susie talked about, and I just wonder, Susie, this is probably the 4th example I've seen where good intention nationally around funding cuts across our local voluntary sector. And I wonder whether there's a way that perhaps you, I, or Jane can just see if we can influence the way that happens nationally, because where I see it all the time just cuts across the great work that happens locally, and that's a real shame.
I mean, I agree. I think we should have another go at this. It's part of a lot. There is a long history of this happening, of government contracting with the larger providers at national level and as I know from my charity commission days, and ignoring excellent local provision. Yeah, I think it's worth having another go.
And finally, Joe Terrell.
Actually, I put my hand down, Nick, so it's the same question as Charlotte. So I'm going to, in terms of picking up the learning and sharing it across locality, so I'm going to pick that up outside with Darren.
Okay, thanks, Joe. Nina, that's been the most fantastically positive start to our day. Thank you very much. The Neighbourhood Friends scheme is clearly leading the way in terms of what we need to do about working as closely with the voluntary sector as we possibly can. And I think we do need to try and learn from what you've done in the East Devon area and spread it as widely as we can across the whole county. So thank you very much for your time. It's been great.
You're very welcome. Thank you. Bye-bye.
Cheers. Thank you. Okay, we have no questions from the public today. So if we could move on, please, to the minutes of the last meeting. I'll just whip through them for matters of accuracy and matters arising page by page. So wave at me frantically if you've got any comments. Page 1, page 2, 3, 4, 5, and Simon?
Just on page 4, Nick, I said something about urgent care for mental health and dementia services not being mentioned in the paper. It wasn't urgent crisis care relating to dementia. It was two things. It was crisis care around mental health and dementia services, two separate things. It's just a kind of a typo really there on page 4.
Okay, can I leave Nikki to just come back to you and agree the correct wording of that?
Yeah.
Okay, great. Thank you, Simon. Page 5 and page 6. Okay, great. That takes us on to the action log. The feedback on learning from the patient experience. I think that actually is supposed to be a generalized idea that we follow up if there's anything that needs to be followed up with patient experience people. I don't think there was anything from the last meeting that really called for a follow-up in the way that there was with the mental health one previously, as an example. So I think we can close that actually. And then number 2, comparison report to be developed, really COVID performance, that's on the agenda, so we can close that once we've dealt with that agenda item today. Okay, so that takes us on to the chair's report. Dr. Johnson, please.
Thanks very much, Nick. So I'll take it as read. I think the couple of things I want to highlight was one, just on the 1st of July that we did our AGM. That's the 3rd year in a row that we've done it in a virtual way. And that's becoming sort of business as usual. But I just wanted to thank the comms team, specifically in public, because actually when with everything that we've been through, the opportunity to highlight those areas of really good work that many of our teams have done, both related to COVID and otherwise, it was really an opportunity to celebrate, as well as being sort of realistic about the challenges that are ahead of us. So Simon and I were able to do that effectively because the comms team had pulled together all of that valuable wealth of information. And then, as always, you know, my thanks to primary care, as well as everywhere else being under pressure. The willingness to engage and to work and think differently about primary care not only sustains its own services, but supports the system within which it operates, has been great. And there's been a number of really positive meetings that I've had with primary care to try and work out how we get the best out of them and do the best for them. But happy to take any questions.
Okay, do you have any questions for Paul? No, in which case we'll move on to the accountable officer's report. Jane,
Great.
Please.
Okay, thank you. I will do the same as Paul and just take things as read. Just to say a few updates, I suppose. So the ICS development and transition continues apace, and obviously the legislation is going through, but meanwhile we're busy working on the plans for that. And certainly checking in with our regional colleagues to make sure we're on the right track, and so far positive feedback on that. Just to say the recruitment to the ICS chair has now started, and the advert I think went out yesterday, so I think the closing date for this round is on the 17th of August, and we will be asking for people, if they are around, to be involved in stakeholder sessions towards the end of August. So we'll keep you posted on that. Within the papers, you'll see quite a lot of bit about the various pressures currently on the system, and which is as a result why we've got people popping in and out of this meeting today. I think it's fair to say, although we've got a fantastic vaccination programme and response, we've got a sort of a perfect storm of challenges in relation to some COVID activity being seen within hospitals and care homes, but also compounded by workforce challenges. So I think at this current moment of time, we are in, as I say, back into the instant control control and command centre approach to how we're doing business in Devon. So just need to bear with us over this next few weeks and months on that. Just want to pick up what Paul said just in terms of general practice and incredible response, but also I think having the GP survey results come through has been really helpful, just again to reflect that actually throughout all of this, the incredible work and good feedback we have from people about the services. So again, just to say, really good to see, and thank you. On top of everything else, we are inundated with cyber attacks pretty regularly. So I just wanted to reassure the board that there is a lot of work happening just to ensure that we are compliant and we have got our data security protection in place. And we've just recently submitted our toolkit, which is for the CCG and general practice, but actually that's also being rolled out across all of our providers as well. But I think it's fair to say at a national level, there's obviously quite a lot of scrutiny about ensuring we've got everything that we need to put in place to ensure that we don't avoid any cyber attack on top of everything else. That'd be the last thing we needed, wouldn't it? And then last thing to say, of course, yesterday the announcement of Amanda Pritchard as our new chief exec for the NHS, which I think is a very positive appointment. And having worked with Amanda personally, as I say, I'm looking forward to getting her down to Devon to visit us when she can. So I think that was all I wanted to flag.
Okay, thank you, Jane. I think we'd all agree that last point, that the appointment of Amanda Pritchard is really, really good news for the NHS. And hopefully it'll generate a bit of continuity of approach from NHS England, which will be really helpful, I think. Now, has Al joined us yet, Nikki? Do you know?
I've just checked and she doesn't appear to be on at the moment. I did ask her to join around about 10ish if she could. I'll just link her, Nick, and see if she can join right now. Okay, well, we'll move on then with the agenda as written. So that takes us on to CCG Objectives. Andrew, do you want to lead us on this?
Yeah, thank you, Chair. I mean, again, I'll take the paper as read, but I do want to highlight a number of points, if that's okay. Basically, as you know, we set up some CCG objectives for 21-22, working closely with our staff across the organisation. And so this is the second update report that we're producing. And I'd like to thank Nick Pearson, who pulled all of this work together to produce the report for you. And as you know, our intention is to report progress quarterly, so the next report will be in October. We normally do a detailed sit down with all of the leads and directors on the objectives, but this time round, because of pressures on everyone's time, given the growing pressures across the system, we've just done this one as a desktop review. So if you please bear that in mind. Of the 5 CCG objectives, 2 are rated as amber and 3 in green, which is a slight improvement on April. And of the 25 actions, so each objective has actions, and there's 25 in total, 4 have improved since April and 3 have gone down. There's 2 actions that are rated as red. And there is a proposal there that governing body approve an extension to deadline for those. So the first one is in Objective 1 Action 3, and that's around producing a systems outcome report. and the new deadline requested is November. And the other is Objective 3 Action 2, which is about resetting the medium-term financial plan. And the proposal is to move that deadline to April 22. You will see if you read the report in detail and compare it to April's, that I guess the area where we've seen most of the deterioration, of course, is the challenging around finances. And no doubt John, if there's any questions around that, can address those. I guess it's safe to say we're also refining the process. So you'll see some dates have gone, and there's a narrative that explains some of the progress and ongoing work. So we're going to look at how we best present that. And also, no doubt, during the course of the year, there may be some new actions. We're keen to keep the objectives as they are and to highlight those that have been completed. But throughout the year, of course, I guess we'll get some new actions that will appear. And again, we'll look at how we refine that. So I've just asked governing body members to note the report, note the progress, and I guess note some of the challenging areas, and to agree to the extension of the deadline of 2 of the actions that's requested.
Okay, questions, comments for Andrew? I've got John Walmsley and then David Greenwell, please. John?
Thank you, Chair. So Andrew, looking at number 2, improved service performance, I think many members of the public and me included might feel that to have that as green for improving service performance may not be as frank and honest with ourselves as we should be. Now the actions we set are around implementing plans, making plans and that side of things. But actually, from a service performance, the outputs and outcomes point of view, green doesn't sit well with me. So can I just have your comments on section 2 being green?
Yeah, of course, John. I think for me, we had that discussion as a team when we were producing the report, because if you look at the actions under that objective, John, they would be green because they're things like implement 111 first, phase 3 restoration plan, integrated performance reporting. Is, I guess, what I mentioned in my commentary. I think what we probably will do is refine some of these, because I guess that section isn't capturing actual service performance. Yeah. So what I could do is work with Joe and colleagues, Joe and John, really, to see if we could refine that to actually see what would be really helpful. But as far as the objectives are concerned, John, you'll see that the ones we're reporting are green. But if you look at the definition of the objective, I think we might need to just refine that one. That's the one that stood out for me, and I think you're absolutely right around that.
Lovely. Thank you, Andrew.
Okay, I had exactly the same question, John, so well done. David, please.
Yeah, I'm afraid mine's very much on the same theme. It's just I'm very uncomfortable with it. It feels like we're patting ourselves on the back with how well we're doing. You know, we really need to, if we're going to say we are an effective organisation, I think we need to back that up with real evidence, not evidence of having plans, but evidence of improved performance. And likewise, having an amber rating for financial sustainability would suggest to most people that there's a fair chance we will be financially sustainable within a very near space, time frame. And I suspect that the time frame in order to achieve financial sustainability is going to be long term, not within a sort of moderate time frame, and B, far from certain. I don't know if John would like to comment on whether he feels it's fair to say that we have a good chance of being financially sustainable in a reasonable period of time.
John, do you want to answer that?
Yes, thanks, Nick, and thanks, David. Absolutely fair challenge. I guess the amber rating reflects uncertainty on a couple of things, doesn't it? So are there a set of conditions where we would be able to return to financially sustainable position within a reasonable amount of time, and even that word reasonable amount of time is subject to judgment, isn't it? You know, I think there are a set of circumstances, but there are a lot of external dependencies around what happens to the allocation for the population, what's the timescale which we expect to exit from the current heightened operational escalation to something that feels a bit more like business as usual. So I think the amber rating reflects, you know, we certainly haven't got that clear trajectory yet, but are there a set of circumstances which would enable us to do so? Yes. And until you can answer that one way or the other, I think it would be too harsh to push it to red. So that was the rationale.
Okay. Does that satisfy you, David?
I think it's still optimistic, and I think the idea that we have demonstrated our effectiveness is also optimistic, and certainly that we've improved performance is optimistic. But you know, it's a, you know, having a red, amber, green rating is quite a it's quite a rough guide, and therefore there's a big space within each colour.
Mm. Yeah. Thank you. I'm going to move on to Simon.
Yeah, thanks, Nick. It's really again about that financial stability objective. Is that really an ambition to get financially stable in the medium term? Pushing the cart down the road, and kind of maybe not ever doing that transformation of moving money from acute to community, which is, after all, the kind of lever that the main lever we've got to actually to turn around Devon, worries me, and so setting the medium-term plan or resetting the medium-term plan may well undermine our long-term plan, and that makes me very anxious that we're going to actually change what we set out to do at the beginning of the year, halfway through the year. Thanks, John.
John, do you want to reply or not?
Yes, please, if I can, Nick. So again, it's helpful. It's helpful clarification, Simon. So the request is just to push that end point for production of the plan back to March 22. So when we set that objective, we were expecting to have emergency financial regime probably for the first half of this year, but would need to be back to business as usual for the second. As things have transpired, then we know we're going to be in a difficult and different set of circumstances the remainder of the year, but expect to need the medium-term plan to return to by April. So we're pushing it back to that extent, but the work that we're doing on the financial plan is absolutely aligned to the changes in the system that we're expecting to make over the next period. So it's not a movement away from what we've committed to do in any way.
Okay, that's great.
Okay. Thanks, John. I've got John Finn and then Graham Turner.
Yeah, it's just to go back to the objective 2 and just to set some of the context around service performance. I think it's important to remember that this is in the context of the H1 plan, and certainly they focus nationally, regionally, and locally around restoration of services rather than service performance. So based with that definition and the H1 plan, no, we were restoring services beyond our H1 plan, and thus the green rating. Now that focus is quite rightly changing towards the performance around the national performance standards, etc., etc. But in relation to those actions, actually, it is, as I said, we have, and when Alison presents some data later on, it'll show how we were actually surpassing our restoration agenda.
So I think the point, though, John, is that we also have a duty to be clear with our public. And if you're a member of the general public reading improved service performance, you wouldn't necessarily move to the definition you've just given.
Okay.
I understand that regionally from the NHS England model, that might be the definition against which we're being judged, but it doesn't appear, does it, that service provision is improving in Devon at the moment if you look at the wider picture. That, I think, is the point that John was making. Graham?
Thank you, Nick. If I could just build on what you've said and on David Greenwell's questions earlier, I think this all goes back to Andrew's answer to the first question, which is if you look at the individual actions, I think the scores are absolutely fine. I don't quarrel with any of the scores related to the actions. But when you conflate those to the objectives, it feels a little awkward for some of them to be scored green. So I think Andrew's proposal to take away the piece of work, have another look at whether we've got the right actions and therefore whether we're giving the right overall score is the right thing to do.
Okay, I think that's a very helpful summary, Graham. So we'll move on there if that's okay with everyone. Is Al with us now? Yes, she is. Hi, Al. Nice to see you. I am. So
hi, Nick.
Do you want to take us through the?
Yeah, I'm just going to share my screen if I can. I am in County Hall, so it should be better than usual, but fingers crossed. Is that working? Oh, it looks like it might be.
Yes, there you go.
So, this presentation links back to a question that I think was raised at a governing body a couple of months ago around looking at current activity levels compared to 2019, discounting last year because clearly it was an atypical year. And so what I've based it on are published data for April and May, but clearly, you know, based on the conversation we've just had, you know, there's more happening since then, and I'm sure we'll touch on some of that. So it's by no means comprehensive, but if there's more that you need, please let me know and I can obviously bring stuff back at a later date. The first thing I wanted to share was this. Now, this is part of the appendix to the integrated performance reports that have been developed for the system and that we will be pulling into the Finance and Performance Committee reporting and Governing Body reporting going forward. So what you will see on a regular basis are comparisons with both 2019 and 2021 and the planned numbers. And you can see there, that's just a snapshot, but I will go through some of the these numbers in a bit more detail. So I've pulled out a few of the key ones, but that shows you in a sort of quite a simple way, although when you see the whole report, there's quite a lot of indicators. It shows you where we are now compared with our plan that John mentioned earlier and compared with last year and the year before. So as I say, I'll just pull out some of that. So in terms of referral levels, at the moment, referrals haven't bounced back yet as we would have expected, and they're currently around 10% down on 2019. And this isn't about demand management. This is just that the demand hasn't yet fed back through to the same extent. 2-week waits has been in a similar position, but is now recovering. And I'm sure John Finn may want to talk about that a bit more. In terms of outpatients, as you'll see, the grey line is the plan. So that's what went into our H1 plan, and that links to what John said around recovery. So outpatient attendances have been above plan, and that's largely around the Elective Recovery Fund and the Accelerator programme. So that we've put in a lot of extra initiatives across the system to try and increase activity. As you can see, the planned levels go up significantly as we go forward. And as I say, this is sort of published data from April and May. We will clearly be adding to that as we go. In terms of electives, again, so I've split out day cases and inpatients, both of which are above plan for April and May, but behind 2019 levels. So again, this is part of that recovery. At the moment, due to bed capacity and other issues, we're not at the same level that we were in 2019. And follow-ups were significantly over plan during April, but as other services have been stood back up, the physical space has been more difficult to find, and therefore they've dropped back during May below the planned levels. But as I say, that's the kind of the elective and outpatient position, and I'm sure John will cover that if you have any questions. I didn't do slides for all the individual diagnostics. I didn't want it to be death by PowerPoint for you all, but just to show you again a snapshot from the IPR around diagnostics. So MRI is currently running at sort of 86, 89% of 1920 levels. CT is above the 1920 levels. Obstetric ultrasound is also below, and echoes are sort of oscillating around. The performance around scopes has been good. It is still below those levels in 1920, but that's where a lot of the focus is around the accelerator program. In terms of emergencies, so looking at the published data in April and May, the overall volume of ED attendances was below 2019 levels. As you know, pressure has been growing on our emergency departments, but it's not just about volumes, it is about the distancing within the department, the need to test people before they're admitted, so the flow through the department and the sort of batching in terms of ambulances. But clearly, as these graphs are added to for June and July, we will see the result of that growing pressure. And one indicator around acuity in the people who are coming in is that our actual non-elective admissions are up on 1920 levels and above the planned level, i.e. the expected level that we put into the H1 plan. Just to sort of bring it more to sort of the current performance, and just to reflect that increase that we've seen in the last couple of weeks. This is a sort of SWOST graph. This is the whole of the SWOST patch, but this shows the red line is the current year. The pale blue line is 1920. So you can see it was actually, if this goes from July to July, it's quite similar until the last sort of couple of months, and there's been a significant gap opened up in terms of the pressure, and as you'll be aware through media reports, SWOST have had their biggest days ever over the last few weeks, and this is just another way of showing that weekly across the different SWOST patches. Back in May, it was very green in terms of their numbers, and then as you move towards the end of June, much more in the way of red in terms of pressure and numbers. So I wasn't planning to do anything else. As I say, I think going forward, this information will be included in a much more clear way within the Finance and Performance Committee reports, and hence flowing through to Governing Body. But very happy to take any questions or to take anything away if there's more that you want.
Okay, thanks, Al. I've got questions from John Walmsley, then Simon, then James Woolbridge.
Thank you, Al. So this is really useful. Hi, this is really useful information, and it does illuminate the problems quite well, and they're very worrying. So for me, I think there might be a correlation between referrals from primary care being down and ED acute admissions being up, and the SWOST ambulances calls being up. So do we have out in the community a large number of people who are becoming more unwell, have been frightened to attend services because of all the COVID pandemic? And if that is the case, then are we in for a very challenging couple of months as these people have more confidence to contact the service, and they're admitted to hospital and they're helped, but it looks as if we have some pent-up demand within the system sitting within primary care, and we need to be, I suppose, going out proactively and looking to help those people as early as possible.
And I don't know if John Finn wants to comment on that, but I think we are keeping in touch with people on the waiting list. So I think there's the people who are waiting, aren't there? Who we're actively keeping in touch with. But as you say, there may well be people who aren't coming forward at all. And I guess the fact that the referrals haven't bounced back to expected levels would reflect that. I'm not sure in terms of the timing of when that's likely to happen, but John may want to comment.
I will. So, John, there is a piece of work been undertaking to understand whether patients are accessing their elective care through ED. At this moment in time, there's no evidence to say that's the case, but there's a decent hypothesis that is the case, and we're happy to report back on that. So I said that's a real issue for us. In terms of clinical validation, I think it'd be good for the governing body to know the level of support there is to patients. So I said in terms of non-clinical validation, that's in place at this moment in time. Every patient who's on a waiting list has been contacted, etc., etc. We are working with general practice a bit more on that, because we've had some feedback that it would be useful for GP to be signposted, for patients to be signposted to their GP if they have some concerns. But that does give a workload issue actually, which we are working through. So I said we do need to answer that question. There are many views nationally and locally in terms of that pent-up demand. Our initial modelling would have predicted that we would have seen that by now, and we're not seeing that. So the work which we're doing through the elective care board actually did sort of predict we would be in an over 100% referral rate at this moment in time, which we're not seeing. So we do need to understand if that pent-up demand is real or if it doesn't exist at the moment.
I'd say we are seeing it, and it's called ED emergency admissions.
Yeah.
But thank you, Chair.
Yeah.
Okay, I've got Simon Kerr next.
Yeah, so I'm not quite sure I agree with that, John Walmsley. My first question is, are we not seeing as many referrals because primary care is doing its work in a different way? Largely it's speaking to people on the phone and seeing a lot less people face to face. That has maybe its own worries for me and for others, but certainly we're working in a different way to the way we were before. My other thought is that if there aren't as many people actually coming into ED, but there is still significant pressure and demand in the system, is the standard operating procedure that the hospitals are using contributing to those delays in terms of flow? Certainly in primary care, that is the case. We are not able to process as many people through our phlebotomy services as we used to be able to, because we've got to wear PPE, wipe down surfaces, masks, gloves, all that sort of thing, which is doubling, if not tripling, the time that we would have taken to do a very simple procedure. We would like perhaps further guidance for a new SOP, perhaps in lieu of changes in national situation in primary care, or you know. So I just wonder how much of that is contributing towards pressure and delay in the hospital sector.
Yeah, and I would think that is a problem. I mean, particularly, as I say, the sort of distancing in ED and testing people before they are admitted, and there's also problems getting people out. Again, it's not reflected in these figures, but over the last few weeks, the numbers of outbreaks in care homes, as you'll all be aware of, making the flow more difficult in terms of discharging as well, and all of that creates problems at the front door. But you know, what SWAST are seeing are they've increased their sort of see and treat and hear and treat rates. You know, they're up to sort of, I think it was 30% hear and treat, but they are still taking significant numbers to ED. So, you know, every day the conversations are about how unprecedented, the word unprecedented is used a lot. But as I say, that's not necessarily shown in these figures, but will be over the coming months. And we do have daily data, albeit unvalidated, that we can look at to assess some of that pressure. But yeah, I think the processes may well be creating delays. So I'll take that back in terms and speak to Sheila about what's happening within the providers.
Okay, thanks, Al. James?
Yeah, thank you, Nick, and thank you, Al. My question relates to the number of serious incidents for March this year, which were at their highest level for 6 years. I'm just wondering if these are on an upward trajectory, or at least if there's any understanding of what might be the cause, whether it might be related to staff exhaustion or staff numbers.
I don't have any data on that with me, James, unfortunately. Can I take that away? Darren's not on the call, is he? I think.
Yeah, absolutely fine.
Oh, Susan's on the call, so Susan might want to comment. I don't have.
Call, but we. Sorry, yes, I'm on the call, Ali, but we don't have data on that. But
you know, we don't know exactly what the reason for that is. I think there are a number of crowding in reasons for the increased activity, and it's being reviewed on a daily basis.
Okay, thank you.
Okay, David.
So I just wanted to try and summarise the data because I think I'm not sure that what the discussion we've had up to now truly reflects the data. So attendances at A&E are down. Attendances at general practice or contacts with general practice are up. So roughly 10% drop in A&E attendances, roughly between 10 and 20% increase in GP attendances, which didn't seem to reflect the conversation we had earlier. There has been a very small increase in admissions, and there has been a big increase in ambulance calls. But the conversation we were having earlier didn't seem to reflect the fact that there's been this drop in A&E attendances and an increase in GP contact. So that was the first thing I wanted to say. And the second thing was about non-elective demand. The figures that we've got presumably predate the suspension of orthopaedic surgery at Torbay and Plymouth. So I presume those figures are going to deteriorate further fairly rapidly.
John, do you want to answer that?
Yeah, they will deteriorate from about 5 weeks ago. Yeah.
Right. Okay. It's 10:30, and we've tried in the past being really religious about taking breaks on the hour, and that's been well received. So I propose that the people who've still got outstanding questions just hold on to their thoughts, and we just take a quick 5-minute break now, and then we'll come back to so I've got Lincoln, Sergeant, sorry, and Joe and John Walmsley when we come back. Okay, so if we're back at 25:02, please, that'd be great. Thank you. Right. Lincoln, did you have a question for Al?
Yes, thanks so much. I just wanted Alison to ask whether in your analysis you've looked at some of the kind of cohorts that typically have issues around inequality of access. So particularly around our equally well ambition, people with LD autism, what is their pattern? So there's a risk that they may not be showing up at all and presenting late as emergency admissions, but equally, how are we tracking that in terms of the calls we're making? Clearly, there is a kind of must do for us around looking at access for people from Black and ethnic minority and also kind of deprived areas. I know the data is a problem there sometimes, but particularly for the LD and autism cohorts, we probably should know them, and just wanted to know how this is playing out in the data.
That's not shown within this data, but there is work going on under the health inequalities work stream, particularly related to the elective recovery fund, which is probably why John's stuck his hand up, whereby actually we are tracking that, and we are making sure that we've got the information. John, did you want to?
It's just to build slightly. I absolutely agree. You know, a lot of the work has been prioritised through our H1 plan, but Sergeant, I'm also doing a paper for the chief executives on Tuesday that answers the majority of those questions. Now, I'll be submitting the paper tomorrow before 5 o'clock. Happy to share that with you at that time, actually, and talk to you direct in terms of the actions that we've in place rather than the planning.
Thanks.
Will do. Okay.
You're on mute, Nick, but I think probably you were coming to me next.
Brilliant piece of chairing that is, isn't it? Yes, thanks, Jo.
Yeah, thank you. Yeah, I was just going back really to a couple of the points that were made. So because David just tried to draw us back to the point actually that contacts with primary care are significantly up. We have seen a reduction around ED, albeit that actually emergency admissions are a bit higher. And obviously just drawing on the point that John made as well. So I think it's just really important to say that I think one of the things that was obviously highlighted in the accountable officers report before around the patient survey around general practice, which was completed in the first part of this year, so January to March, so a little bit out of date, but it's relatively recent. And actually, you know, we've improved, patient experience has improved in terms of people's experience of general practice and accessing general practice. And although we know there are some specific issues, we absolutely do, but actually that doesn't point to people not being able to get an appointment with their GP. But we are doing a piece of work in the ED departments, which will enable us to ask individuals why they're turning up to ED and whether they feel that if there was something more appropriate there, or if there was a better way to access other services, whether there's something we can do differently. So I think it's just important just to make that point. And the other piece of work that we've been doing this week, which Paul Johnson has been leading, is around ways to free up some urgent capacity within general practice as well, just to help support general practice being able to cope with the demand, but also the rest of the system as well.
Okay, great. That's very helpful, Jo. Thanks. Paul?
So I was just going to talk about, there's lots of discussion here about what the data is or isn't showing with regards to ED and how does that reflect to primary care. And I think we've just got to make sure we're talking like for like. So our ED data that we've just had goes up to the end of May. Our SWOS data, where you see that big acceleration, is much more up to date than that. And what we don't know, and we're making assumptions here, is that under attendance at ED is continuing despite our experience in primary care and despite what we're seeing in SWOS. Now, every bit of anecdotal evidence and evidence from our ED departments and our SWOS and the pressures the system under would say that that's just not true. So I just think we've just got to be making sure that we are getting our timelines of the data that we're looking at right. because otherwise I think we are at risk of drawing, making suppositions and extrapolations that aren't necessarily data driven.
I think that's right, Paul. And the reason I didn't show other more recent data is that it is unvalidated data. But yeah, we do have daily data, and as you say, the daily calls reflect growing pressure and have done for the last 2, 3, 4 weeks.
Okay, thanks, Al. Graham Turner.
Yeah, thank you, Nick. If I could build on what Paul just said about making sure we're comparing like with like, I think we need to be really careful using language about reduced emergency department attendances, because you have to look at capacity. If because of social distancing and staff shortages and infection control, the capacity is 20% less than it was in 2019, they can still be 100% full now, even with reduced numbers. And that obviously is having pressures. And I guess you could make the same point about primary care as well. You have to look at capacity as well as attendances. So this information is really useful, but let's look at the round.
Yeah, thank you.
And on that subject of looking at things in the round, I think it's also important for us to remember that using the comparator of 1920 performance for diagnostics is the fact that we're overperforming what we're doing in 1920. We know is what the system needs to be able to sustain decent performance, because in 1920 we provided 15% of the national long waiters for diagnostics when we're only serving 7% of the national population. So that's not, it's not really a particularly useful benchmark to be achieving. I know that's what we've been monitored on by NHS England, but actually if we only can maintain diagnostics at that level, it's never going to help us sort out the underlying problems, is it?
Okay.
Okay. Any other questions for Al? Simon?
Yeah, Al, I've asked you this before, but have we got, picking up Graham's point, have we got a capacity plan? Have we got a sort of prediction of staffing that we will have over the next 3 months in the emergency department, given that there's lots of people on holiday and people are needing a rest in the summer? Have we got us kind of a sort of planner of that? Because that's surely going to create more delay in the system if we haven't.
Yeah, we've got the plans that went in H1 where we had planned for activity for the first 6 months, but we've also been working on a sort of a seasonal plan similar to the winter plan, but really for the summer, and that includes particular initiatives and schemes. Some of the schemes that happen through the winter, keeping them going in the summer. There are daily silver calls at the moment, and I think gold calls now more than once a week, picking up issues around trusts that need support, mutual aid, system action. But the work, there's been a lot of work around getting people back to work. You'll know that the guidance changed recently around health workers being able to not isolate, so making sure we have a system view of that and we're being consistent. So there's a lot of work going on, but it's quite difficult to plan. We can plan for the annual leave. I think the sort of the isolation was the thing that's really made a difference over the last few weeks, but we won't know. I think we'll know going forward what a difference the change in the guidance has made. But yeah, the operational plans took account of sickness and annual leave, but not around this huge isolation impact that we've had.
Okay, thanks, Al.
Okay.
I've got Jane, please.
Well, again, I suppose John's got his hand up, but I think we just need to move on. But I suppose just to reinforce the sort of, if we go back to the point when this paper was asked for, that was a time when we were not in such a sort of the latest wave. So the reason why we included that last slide about SWOS was just, I suppose, just as an opportunity just to flag, you know, the pressures I think we all know we're under, but it wasn't necessarily in relation to doing that, just comparison. Just in answer to your question, Simon, about the modelling and as I say, the planning, Al is right, we've got the seasonal plan, but we have refreshed the latest sort of modelling in terms of trying to identify the variables that we know about it, which can help us predict what this next wave is. So as I say, it's quite a live piece of work at the moment, but as Al says, there are lots of different components of it which relate to you know, staff sickness and also the isolation. So I suppose it is work in progress, but as I say, if we go back to the original, the idea was just to sort of give a snapshot, but the reality is things have moved on since that original request. So you know, but we are using as much modelling as we can, and as I say, the incident sort of approach is back in full swing to help support that.
It is.
Okay. Thanks very much, Al.
Thank you.
We'll let you go, because I know you've got to go and chair a silver call.
Yes.
So that we'll move on then to the Governing Body Effectiveness Report. This is pretty straightforward document. I propose that we take it as read. There are some recommendations on pages 59 and 60 of the report, which is section 5 for those of you that are not using board packs. Is there anything, Andrew, you want to say in support of this, or can we just note it and move on?
Yeah, I would note it and move on. Nick, I think you've covered it.
Okay, so can I just check, has anyone got any questions about this piece of work? And is everyone happy to support the recommendations in it? Yeah, okay, that's great. So then we'll move on to population health management. Jo.
Thank you, Chair. So I'm going to, like Andrew, just take the report as read. I think it's fairly straightforward and explanatory. The reason for bringing it here was a request from Governing Body to get an update on population health management progress. And I think we've managed over the last few months, we've managed to make some really good progress because we've had some funding nationally through the Ageing Well programme. And one of the three things that funding was specifically purposed for was around that proactive case management, case finding of patients, which has enabled really us to fund for an 18-month period a team of individuals, so to provide analytical support, but also to help support the localities in the LCPs to come together to have those conversations using the data to understand what differently we can do for either cohorts of individuals or specifically individuals themselves. So I think it feels like we've made some good progress on there. We've still got some issues to resolve around IG. I don't think we need to go into the detail of those, but they are that is a piece of work that is ongoing at the moment. I suppose probably the thing to say just that's to update from the time of writing of this report is, as Jane mentioned just a moment ago, we have gone back into sort of incident response mode. So that does mean, as you've just heard, the system is very busy. So probably we just need to reflect on that in terms of the timescale we had set up for action learning sets for each of the primary care networks, with locality community teams, mental health teams coming together to discuss the use of the data and to devise a plan for those cohorts of patients moving forward. So we might just need to reflect on that, whether that's still the right timescale or not to start that in September. But everybody, I can say, particularly primary care, are very, very keen to start using this and to learn from those areas that have already worked with us on this. So I'll just pause there and stop for any questions.
Okay, Susie, please.
I think this is really, really helpful update. The one thing that seems to me to be the paper's slightly silent on is how this goes when we finally reach the patient, the citizen, and whether they understand the process by which they've been identified and how they react to that, and whether they agree with what the system thinks they need support with, and that the sort of the public acceptability and impact and usability, I think is quite important.
Yeah, I think Susie, that's really helpful. I think you're absolutely right. I think the paper focuses on the process for the kind of rollout and the use of, but doesn't really focus at this point on the sort of ongoing evaluation, particularly focusing on the patient and the family's experience of. So I think I'm confident we've got that in the timeline, and we've got people working with us to do that a sort of thorough sort of academic review and analysis, along with that sort of pulling together that qualitative experience. But I think I think once we've been running this for probably another 6 months, when we get into that sort of action learning set, we probably want to bring back something, whether that's here, whether that's through the integrated care programme board, to review the experience of individuals as well, because I'm sure there'll be some learning in there for us.
As long as we're doing that actively, that's great. Thank you.
Okay. Thanks, Susie. Simon Kerr.
Yeah, I build on Susie's point, really. I'd be really interesting to know, if we are wave 2, I think we were population health management, what did wave 1 find? Do we really know that this makes differences, outcomes better? And actually, how did they do it? Because for me, it's going to be at that point of delivery on the front line, where you've got all your QOF to do, and all your diabetics and your hypertensives and your rheumatoids, and we've got to get these cohorts of patients in anyway. We're going to have to either have a parallel set of workers who are suddenly saying, right, we'll have all the lonely socially deprived group because they've been identified in our action learning set, but we've still got to get the diabetics and the hypertensives and the rheumatoids in. So it's, how did they actually do it with a given workforce that's only so big? I would really love to know that from wave 1.
Yeah, so I know Paul wants to come in, so I'll hand over to Paul in the first instance.
So Simon, I think it's a really good point about how do we resource this. So the plan talks about how do we resource the availability of the data and the assessment of the data. How do we resource that coordination at place? There is some funding available to free up some clinician time. A lot of that will be around identifying those cohorts and then agreeing the intervention. If we look at our learning so far, all of our 5 pilots had a multidisciplinary approach to any intervention that they put in place. So it wasn't about what does primary care do differently, it was what do we do as a local system differently. So if done right, it's not about finding more resource, it's just being about more clever and more collaborative in the way that you use that resource, and really dependent upon what are those community assets, going back to what we had in our presentation this morning. So how do we use some of those community assets and local authority and community services and primary care as a collaborative that actually does the job we're doing now, but more efficiently and more targeted and more effectively with the patients, rather than what extra stuff do we need to do?
Yeah, the only thing I'd just add to that, Simon, is this can't feel like a separate job to do. In the locality, whether that's in primary care, whether that's with the community teams. This is a way of identifying certain cohorts and trying to come up with some different solutions and really focusing, but it can't feel like something very separate. It has to be embedded as business as usual. And I think even the people who've gone through the first wave, there is still work to do, but it has to, and it will over time will feel like the norm rather than this is an additional thing to do over here.
Okay, thanks. Nick Kennedy, please.
Thank you. I'm very supportive of this, and I mean, it's clearly a national priority and an objective, and may well provide some fantastic benefits. In theory, it will anyway. But I do note that you're very clear that the financial benefits are the evidence isn't there for that, and I would suggest that the other benefits, whilst in theory may be very good, we haven't, as has just been said, we don't know what the benefits are really going to be. So my question really is just what level of oversight are we going to have, and when, to be able to make sure that we're not heading down an expensive path that actually isn't going to achieve anything very much, despite the way it's been built up at the moment. What controls are we going to have to make sure that we are getting value from this in the short to medium term and on an ongoing basis?
Yeah, absolutely. No, really good question, Nick. And I'd want to assure you that that is absolutely part of the ongoing evaluation process. So ensuring that we get the value for money element from this, as well as patient experience, etc., is a key part of the evaluation that we're working up. I think it is too early to tell, because I think, you know, the wave 2 sites have kind of only just finished. So I think it really genuinely is too early to tell, but that will be a big part of the evaluation that we will do moving forward. The only other thing that I'd say about, you know, this is an expensive thing that we've set up, I suppose I don't see it quite in that way. So yes, we've had to do some upfront investment, but actually I think when people start to use the data, we've got the data set up, having multidisciplinary team meetings becomes a kind of way of doing things. Actually, we know in some localities, so Coastal's a really good example, where they do that already, and that's not extra. That doesn't need to be funded separately and extra. So I'd be confident as we move forward, it won't feel like an expensive extra to do it, but it will be business as usual.
Thank you. Okay. Thanks, Nick. Judy?
Thank you. So I wanted to talk about how we make it easier for people to understand what this is. So I think Joe's absolutely right. It is business as usual. And in fact, what I think this is doing is, in some ways, adding to what many practices have done for years, which is work out that they have a cohort of people that whose needs are similar, and they might shift the way they work as a practice to focus on that. And what I understand from doing the training, reading the training material, is that this makes that much more data-driven, much more robust. And I think that one of the best examples in the training material is about a practice that decided to focus on the pre-frailty group, who you might not immediately think you should put all your energy into because they're not the ones turning up with all the problems, but that was a really good investment of their time, their energy, their resources, whatever. So I'm wondering, Joe, as we go along, if we can find a way to get maybe each time we do a report on this anywhere, localities, whatever, some case examples in that just give people that sense of how it works, rather than it's a big title and a big program with a lot of money being invested, because actually I think this is instinctive to most general practices when they're not running to just keep up with the crises at the moment.
Yeah, I think that's a really good suggestion, Judy, because I think you make a really good point about what this is. And what this isn't and what's gone before. So many of us will have been around through virtual wards, Devon predictive model, and actually this isn't new necessarily. I think what's different about this is the quality of the information that we've got this time, the breadth of the information, and the way that will be systematically used, and to try and reduce some of that variability we've got in how and where that's done across the patch. I think that's the key difference. I think the suggestion, Judy, of what does it actually feel like on the ground for the staff, but for the patients as well at the end of that, I think it's a really good suggestion.
And I think it helps us as decision makers, and the locality groups, I think, will find it easier, because you just get so much stuff coming at you in, 300 pages of reports. So 2 or 3 good stories that explain how something works in practice is so much easier for people to retain, and will be great for taking it forward. I understand stories are not evidence, but they're a good way of showcasing evidence.
Okay, thank you, Judy. We've got David, and then we'll move on. Thank you, David.
So I just wanted to just check that when we use this information to redirect services, priorities, funding to particular groups of people who the data suggests we should be, that there's an EQIA process that means that if I'm in a minority, if my particular need group is in a minority in an area, I don't get left behind. So if I live in an area with very high numbers of elderly people, but I'm a young person with particular needs as a young person, that my needs don't get ignored, because the data suggests that the big need in the area is to deal with elderly people. Do you understand what I mean? So I'm just really making sure that in redirecting our services towards the big needs in an area, we don't lose sight of the people who are in a minority.
Yeah, I think you make a really good point, David, and I suppose never before has kind of inequalities, I think, been at the forefront of our minds in our particularly in our commissioning at the moment. And I think the good thing about the data that we've got access to, and at the different levels of the data we've got access to, we can use this data at a very high system level. We can use it at locality level for doing exactly what you've just said in terms of looking at cohorts of patients, but we can also then use it at a practice and an individual level to look at individuals. So I don't think there's anything preventing us from doing that, other than the fact of having it in the forefront of our minds, that we need to be doing that QEIA process. We need to constantly be asking ourselves the question about, are we increasing inequalities, or are we not helping reduce inequalities for individuals? So I think the data's there that enables us to do it. I think probably there's something I will just take back around the toolkit that we use, and we're going to use to roll this out through the ALSs, is how prominent that piece around inequalities is within there. So I think that's something I can take away, David, to see how we make sure that gets systematized and not forgotten.
Thanks.
Okay. Thanks, David. I've got Simon Kerr. And
just quickly say, I didn't want anyone to get the impression that I'm not an enthusiast for this. I've been working with data, from Dr. Foster times to POP schemes to Devon predictive model all the time. There's some really interesting work coming out of Honiton practice, where they've been segmenting their own population and learning to provide the care in a different way to different types of that population. And I think that's really, really interesting, how you can actually, some people who send an e-consult will not respond if you respond to them in a certain way, and others will respond in a different way. So I think understanding how different groups of people will respond to different types of provision is really interesting. And I think that's the sort of thing that's developing out of this too.
Yep. Okay, thanks, Simon. Right, let's move on then to the minor injury unit. John Finn, do you want to take us through this?
That's good, thank you. I'm just responding to a request by the governing body to have an update on current temporary closures of MIUs. So I'll take the paper as read, but I'll just highlight the important issue before taking any questions or feedback. In terms of the context and background, in terms of Northern Devon, North Devon Hospital Trust temporarily closed Ilfracombe and Bedford minor injury units at the start of the COVID pandemic in March 20. This was in terms of quality and safety issue, in terms of using their highly skilled staff to support their ED department, where there was a requirement for extra space and staffing to provide a safe service. In terms of South Devon, slightly different position in terms of Dawlish minor injury unit. Open hours were closed at the end of July 19, following agreement with the CCG in order to provide a safe and consistent service level. In March 20, similar to North Devon, in response to the COVID pandemic, Torbay and South Devon NHS Foundation Trust agreed with the CCG that it would be a temporary closure from March 20 onwards, actually, again enabling the concentration of staff on the Newton Abbott Urgent Treatment Centre. In order to provide a safe service. The current position is that those staff moved from the MIUs are still required to support the ED in North Devon and the UTC in South Devon to maintain health and safety and well-being of patients. Both trusts are actively recruiting to their workforce, and once recruited and backfilled, those MIU staff will be available to return. In terms of what we're doing in the interim to support patients, in terms of Bedford and Ilfracombe, ongoing GP support in terms of minor injury services in place Monday to Friday. It's a walk-in service and also directed by NHS 111. And additionally, from June 19th of this year, there's a weekend MIU service in Ilfracombe, which is supplied by a private ambulance staff. In terms of South Devon, Newton Abbot is still open 7 days a week, 8 a.m. to 8 p.m. And for the South Devon population, there's an MIU in Kingsbridge. So in summary, both trusts remain committed to the provision of local urgent care services and are actively recruiting the staff required to reopen these services after the temporary closure.
Okay, thank you, John. I've got Alison and then Judy, please. Alison.
Thank you, Chair. John, if I was a member of the public listening to this, I'd be quite confused. I'd feel I was getting a mixed message because I'm being asked not to go to A&E unless it's an emergency. But a lot of the options for me would have been a minor injuries unit and they're not available. So I think we need to acknowledge we're giving a mixed message, but also to say, do we have a plan for when some of these units will be up and operational again and a timescale for that?
Yeah. So in terms of the mixed message, I think it's a really, really good point. That's why in terms of North Devon, where we listen to patients on that issue, and that's why we introduced the GP service in both Bideford and Ilfracombe. Now it doesn't meet the needs. It didn't meet the needs of the patients at weekends, but that's exactly to counter that mixed message. In terms of a clear timeline, we discussed a lot about current pressures in the urgent care system. The timeline is when they're able to recruit those staff, basically, it will probably take 6 to 8 weeks to reopen those units, basically. But we do need to recruit those staff before that introduction of that service again.
Okay, thank you.
Okay, thanks, Alison. Judy?
Okay, I want to pose a challenge. I don't underestimate how nightmarish it must be operating an emergency department at the moment. But I have a nervousness that it isn't shortage of staff for the MIUs, it's shortage of staff as a whole, and we're making a choice, we, the system, the individual managers, to staff the emergency department, not the minor injury unit, because that is where people are turning up. And so what we're doing is reinforcing for the public that you can't rely on minor injuries units. Don't even think of going to them, because actually they might be closed or only half open and you never know what their hours are going to be. So in the middle of this awful crisis around people, coming forward in massive numbers, it is almost exactly the time that we should make sure that at least one of the minor injuries units in our system is operating fully, so that we can really see how well it can contribute to the system. But if you keep taking stuff away from a service, patients won't trust it, they won't use it. So I know you can't, I'm not expecting you, John, to answer on the spot, but to all of you really, as you're thinking through how to manage this big influx we have of extra emergency patients, let's not fall foul of the classic thing, which is you pull it out of the newer, the less understood service. That would be my request of you.
So in terms of the decision to do this, this would be a trust-based issue based on safety, and I said that was rigorously went through in both organisations. So it wasn't an active decision to stand something down. It was in a situation which is not sufficient staff to staff an enhanced ED. This was within the balance of risk. But I do agree with you totally agree with you in terms of the mixed messages to the public. And I said there will be a paper presented shortly in terms of our strategy to enhance and ensure a consistent approach to out-of-hospital urgent care, as there have been there are different approaches across the county, which are quite hard to understand for the member of the public.
Nick, may I just come back on that? John, I understand it's a safety decision, but it's still a choice. If we thought that the minor injury unit or the urgent treatment centre was the most important place, we would move staff from somewhere else to cover that. So of course safety is relevant, of course number of staff. The recent isolation stuff has made it difficult, but we're falling back too quickly on staff shortages, patient safety, and I understand it's the trusts making the decision too, and they need to. I'm asking you as a group to just rethink whether what you're doing is undermining a model that we're encouraging patients to use. And it's not you personally, it's we, the system. So let's just step back and think about that a tiny bit.
Will do.
Okay, thanks, Judy. Andrew?
Yeah, just to highlight, I guess, what Judy's just said a little bit more. So it has made it harder, Judy, to point people to alternative solutions, because you're quite right, some of them are limited. But where we have had active centres like in Plymouth, we've really pushed those facilities and marketed them. So where they've been open, we've really done a lot to do that. And obviously we're pushing a lot of people obviously to think 111 first as well, which has led to 2,000 extra calls a day. That in itself brings other challenges. But I'm looking forward to John's new strategy where we do have somewhere that we can actively promote a regular service that's open with regular times and services that people understand that in them. When we get there, I think that will make the job much easier.
Okay. Thanks, Andrew. I'm just reading a couple of comments in the chat. Okay. Right, we'll move on then, I think. So that takes us on to two sections that are predominantly for information, the Local Care Partnership reports and the Assurance Committee Chairs reports. So if we go through the LCP reports, I'll invite the chairs to, well, not the chairs, but the locality GPs to just raise any issues that they think are worthy. So Sheila's not with us for the Plymouth one, so I'll suggest we take that as read, and I'll try to take any questions if anyone's got any about the Plymouth report. No. Okay, then we'll move on to South. David?
Yeah, thanks very much. I haven't got very much to add. I have to say, for the second month running, this was a rewrite, partly because we felt that the first iteration didn't accurately reflect the pressure that the South is under, and I guess we didn't want to give you an overly positive view, and particularly issues of concern are basically capacity and management to manage all the difficulties in flow in the system, but also just the demand being increased, which we've heard about all morning. In terms of the structure, we now have an established executive group and a delivery group, which Derek has taken over chairing, so that the structure of the LCP feels a bit more solid now. And in the text, you'll see that actually they've started talking about the priorities for those two groups. Again, local challenges, it's all about urgent care, and primary care really is what's really keeping everybody awake at night in the South. And there's a series of interventions there which are quite well described. So I think I'm going to leave it there, and if there are any questions, happy for either myself or Judy to take those.
Great, thank you. Any questions for David or Judy? No. Okay, then we'll move on to Eastern. Simon?
Thanks, Nick. I think it's worth saying that the Eastern system has been really very much challenged, as I know all the other systems have, but perhaps I've seen for the first time some of our acute trust execs really struggling with the challenge that they've had, and putting in all the changes that they would normally make to move themselves away from Opal 4, which they don't go into very often at all, back to Opal 3, and still finding that they're in Opal 4 at the end of the day. So some real challenge there for them. But having said that, I think our delivery group and the relationships and the friendships we've made, I think, are really starting to show some benefits in terms of us all feeling the pressure together and being able to share ideas together on our weekly call. So that's some good news. And I think we're really beginning to sort of see some of the outcomes of that in terms of understanding how we can each work in each other's worlds and try to help with that. So I had some useful conversations with the Chief Operations Officer in the RD&E this week. I think the other piece of news really since last time was I shared a paper from the Sea Change organisation at Budley Salton, which I think many of you saw. And from what I know, we're coming to some arrangement with them to support them going forward with a financial offer, but with a great expectation that it will become a financially sustainable organisation going forward. So there's some progress there, and thank you for some of your comments that you fed back to me, which I fed back to the people at Sea Change, because some of that was very positive. That's probably all. I guess building on the relationships we built in the delivery group, there is going to be planned to be a sort of working group, I think a real day in October, which we're trying to set up to all get together to actually look each other in the eyes and see how best we can work together. The executive group have got some very clear ideas about areas that they want to work on together. And there's some really interesting work going on in my locality, in my neighbourhood, around primary care mental health work and support to us in general practice through a primary care mental health team, which I think is leading the way across Devon as to how those workers can support primary care. So I can talk more about that another time, but so maybe questions.
Okay, any questions? Nick Kennedy.
Thank you, Simon. Just in your report, the issues of concern or risk, you talk about system data protection officers to resolve information governance issues. And seeing we've just been talking about population health management, can you expand on that? Is that a big issue for you or more widely, as you seem to say?
So I can't expand on that for you, Nick, and maybe for the people on this call who can say more about that than I can. I know Paul was involved in that conversation and updated us a little bit last time. I think it's still an ongoing issue. I don't know whether, Paul, you have more information on that one than I have.
Nothing yet, no, Simon, but I can bring back as soon as I've got anything more.
Okay, great. Thank you, Simon. Then the Northern, John.
Thank you, Chair. So I'll take the report as read. I think the North is experiencing similar pressures that the rest of Devon is seeing. Particularly, we've had challenges around availability of consultants and our use of locums, but the NDHT is working hard to resolve those issues. I suppose the important thing is the development of our local care partnership. We have two main groups. One is the delivery group for health and care. That's been working well, and that's all about relationships and getting all the stakeholders together. So that's one part, one leg of our local system. And the other leg is One Northern Devon, which is about those wider partnerships. Both those bits of our system are starting to work better together. But I suppose we haven't reached the stage where all partners are completely signed up members of a system and able to, in some ways, put the system before their own individual organizations. That's always a big ask of any organization, to put the wider system first. We have seen it across Devon with mutual aid. And I think slowly we're getting that concept through in our LCPs. So it is going fairly well. We too have an executive group, and we're exploring how that group is maybe more strategic in viewing things. So we are developing local care partnership. I think that when I go back to the commitment to partnership working, I think there's a mention there about our community developers. So we have some concerns about the long-term sustainability of that concept, of that program. And I think what we have to learn, certainly through One Northern Devon, is when we start an initiative that goes well, then that needs to be evidenced. It needs to be have the outcomes quite demonstrable, and then needs to be business as usual. And it's that trick about getting from initiation, implementation to long-term sustainability that we have yet to develop well. And that is about partnership working. But we're on a journey, and I think it's going reasonably well for this stage. So I'm happy to take any questions.
Any questions for John? No? Okay, then finally we've got Plymouth and West Devon. I'll take any questions if anyone's got. I don't have anything to add to the report as it's written. Does anyone have any questions? Judy?
I'm just wanting to ask about West Devon, and at a previous locality report, there was some sense in which they were playing catch up. And I want to understand how it's working. And it may be, Nick, that this is not an appropriate question to you and we need to come back on it, but how is it managing in terms of making sure that it's connected to things, but it's still very much a small locality? Has it managed to catch up with others in terms of its structures and its engagement processes and things?
So the honest answer is I don't know the answer to that question, Judy, so I'm not going to try and make it up as I go along. I think we'll ask that of Derek and get him to provide us an answer for next meeting. Unless,
Well,
Jane, do you want to say something about it?
I'll just say a couple of things really. I mean, I know that I've joined a couple of the meetings, and to be honest, I think they are catching up pretty quickly in a nutshell. So and Michelle Thomas, who's co-chairing and supporting that, has got the bit between her teeth, and I'm seeing quite a lot of progress. So I think we can definitely bring back an update, but I think that it's pretty positive at the moment.
That's great. Thank you.
Okay. Thank you. So that takes us on to the Assurance Committee Chair's reports, starting with the Audit Committee, which is from me. The report is fairly self-explanatory. I think the only thing I just need to draw the board's attention to is the risk report, which is attached to the agenda. And this was because the Audit Committee conducted its annual review of the risk structure around the organisation, and we just need the governing body to support the risk management framework. Ginny, did you want to add anything? You've got your hand up.
No, so I was just going to reiterate that point really, just for the governing body to note that we, the Audit Committee, approved the risk management framework and reviewed the risk appetite statement as well, and all of that's in the documentation you've got there.
Yeah, okay. So any questions on the Audit Committee? No, in which case we'll go on to Finance and Performance. Graham?
Thank you, Chair. I take the report as read, but I'd just like to draw 3 items to the attention of governing body, and I'll do them in reverse order. Firstly, the committee made a decision to proceed with the integrated urgent care procurement, and that's after the work that Judy has led in the procurement oversight group. Secondly, there's a note there about H2 planning, and John Dowell might want to say more about that. There is a potential cost reduction target coming in the second half of this year of 3%. And given all that we've talked about the current operational pressures and so on, it's very clear that's going to be a very challenging target should that come. Even were it postponed, it will come at some point. If not in the latter half of this year, it will come perhaps into next year. Sorry to be the bearer of bad news. And the last one is just, and I think actually it will be picked up in the quality report that comes later. The committee was concerned to read again about inappropriate out-of-area placements in mental health. The governing body will remember that back in March, we had a presentation from a lady called Debbie Francis, who talked about her daughter and how she'd been treated by 14 different psychiatrists in 3 years in 6 hospitals, none of which were in Devon. And I'm afraid Devon is still an outlier in terms of inappropriate out of area placements for mental health patients. And despite everybody's best efforts, it remains a really difficult problem. But as I say, I think it's mentioned in the next report. Thank you.
Okay, thanks, Graham. Any questions for Graham? No. Okay, so quality. Gaynor, are you going to cover this in Glynis's absence?
Yes, thank you. There's 3 bits to highlight within the paper to the board. One of them isn't the out of hospital placements, but I'm happy to for everybody to discuss that as well. The 3 points that we wanted to highlight to the board, we've covered in some detail, I think, in the previous papers, which is the waiting times for elective care, as well as the SWOST demand and capacity. So the increase in demand and the lack of capacity for them, and that they're struggling. And we know this is a national issue. Just to there may be other points that people want to raise there, but there is another point that I asked to be put in the paper to make sure governing body had eyesight on, which was the UHP's aseptic suite, and due to the facilities not being really fit for purpose, they do have a new build in 2022 that is going to be progress, but it's how we mitigate any risk of the service, really, because when we discussed it at quality assurance, there were no contingency plans if the actual building was, did fail. It is on a high risk at the moment on the risk register, and it has, datex have been put in. But really what I'd like the governing body to be cited on is what have we got in place as far as mutual aid to provide a service if this infrastructure carries on to fail.
Okay, thanks, Gaynor. Any questions for Gaynor? No. Oh, yes, Graham. Go on, Graham.
Thank you, Gaynor. I've got a question on a point I don't think it's one you raised. It's about autism and the continuing poor performance, particularly around children and young people who are waiting for assessments. Alison very kindly circulated recently a new national strategy on autism. So I just wanted to ask you or the executive whether at some point we could have some sort of assessment on what we're going to do as a CCG to implement the proposals in that strategy. I know it's a 5-year strategy and not everything can be done in year 1, and we've already talked about all the pressures facing us, but it would be useful at some point just to have some feedback, either through your committee or to governing body, about how we're going to move forward on dealing with that strategy, because the current position is really not very good.
Yeah, thanks, Graham. And I think we did discuss the autism strategy at the last meeting, and we have asked for that to be presented on where we are, because we did have a presentation back in April that said, and I think Alison was at that committee, and it did say that we were going to reach our target by October. Now that does not look like it's going to be the case. So we have asked at the next meeting for them to present actually where we are and what we're going to do to mitigate that risk. So I will make sure that's brought forward.
Thank you, Gaynor. I wasn't aware of that. Thank you.
Sorry, can I come in? Is that okay?
Yeah, okay, go on.
Yeah, sorry, apologies for dipping out, but I think I just came back in at the right time there. So yeah, just to let you know, Graham, so I've asked the Learning Disability and Autism team to review the strategy. So they're going to undertake a gap analysis that will come back through commissioning committee, so we can report that back here. Just on the children's waiting list, so I've formally written to the provider just to ask for an update, because we're falling behind on the trajectory that we've got in place, as you've mentioned. I have this week been given some assurances about them being able to hit that. I think there's a little bit more work to do, though, to understand the detailed action plans around that. But very happy, I will very happy to update either outside of governing body or through commissioning committee once we've worked through that over the next few weeks.
Okay, that's very helpful, Jo. Thanks. So we've got Simon Kerr next, please.
Yeah, thank you, Nick. Yeah, I was just going to come back about the autism, because that does come to commissioning committee, as Jo says, and we look at that. I haven't got the answer to Gayna's septic area. I was at quality committee, so I'm aware of that issue. I don't know whether anyone else has, but I wanted, just if I may, just go back to the hospital discharge programme, which is in the finance report. That's obviously funding, I think, ongoing this year in H1 for that, but and I imagine that quite a lot of our flow is dependent upon that. I just wonder if that is likely to continue in H2, and if it doesn't, then what might be the impact on flow? Do we have any idea of that? Can anyone answer that?
Can I come in on that?
Yeah,
Nick,
go on, John.
So the answer is we don't know, as in it's not confirmed yet that it will continue into H2, but it is highly likely that it will. That's certainly the discussion that NHS England are having at governmental level at the moment, is for continuation to H2. We have been doing a lot of planning, both operational and financial, with local authority colleagues about maintaining the benefit to flow that we get through the sort of behavioural side of what's happened off the back of hospital discharge programme, and just working through from both the council perspective and the NHS perspective what that would mean financially, such that we can try and keep it going, almost with or without the benefit of external funding. But certainly we're expecting it to continue for H2, uncertain again beyond that.
Thanks, John.
Okay, thanks, Simon. We've got Susie now, please.
Thank you. These waiting lists, the SALT waiting lists and the autism spectrum waiting lists, are a really good example of where one part of the system is systematically disadvantaging another part of the system. It's not just a problem for the children and their families, it's a problem for the education system, because schools are given extra money once these assessments are confirmed, and they don't get the extra money until that happens, which means effectively that if a child is waiting for 2 years for an assessment, they're still having to be taught, but the school doesn't get any extra funding for that. So that disadvantages all children, and therefore makes it more difficult to address education inequalities, which in a turn, of course, have impacts long-term on health inequalities. So addressing this is crucially important.
I think we'd all agree with that, Susie. Quite what we can do about it is a more challenging question. But that's no reason to not deal with the question. Okay, Jo, have you got your hand up or not? This yeah, okay, great, thanks.
Yeah, no, I was just going to respond to Susie because she makes a really valid point, and that's why, so through the long-term plan development, we have absolutely prioritised those 2 areas as our game changers for this year, alongside working with our local authority colleagues and education as well. So I think we've mentioned the piece of work that we're doing around autism, but just wanted to assure, so the commissioning committee last time we were asked to look at speech and language therapy as well, so I've got a briefing in terms of where we are against speech and language therapy, but there is funding that's gone in, so we will be looking again, as I said, to work with the provider to make sure that we start to see a waiting list reduction there, and that we get a trajectory and we can be really clear about what the end point is, and anything additional that we need to do as commissioners to help support that.
You're on mute, Nick.
Susie, did you want to come back, or is that just a legacy hand that you've got up?
Sorry, apologies.
That's all right. Thanks. Judy, please.
I was just going to ask Joe whether there is anything more that we as a CCG can do to help around this, because I sort of feel for the 2.5 years I've been on the CCG, we've been talking about trying to get our providers to reduce their waiting lists in these areas, the autism and the SALT. And I don't know, I know you've given them extra money so they can recruit extra staff. And I know from reading the figures that you've got quite high targets for them to meet this year. But one feels a sense of impotence in a way about what is it that can be done? Why is it that other places don't have this same level of problem? And Susie's point about the impact on the education department is supplemented also by the impact on family health when you have a child whose needs are not being met. So this is one area where I suppose I'm sure as an executive you're doing a lot to handle it, but what more could we do that might support? Should we invite the providers to come and talk to us? We often hear from patients, but we don't often hear from the providers on our CCG meetings. So it was just, would you like to come back to us when you've had a chance to think about this and say it would help us with the commissioning and improving of this service if the CCG could help in the following ways? I don't know what.
No, thanks, Judy. And you give me an opportunity just to go back and mention the children's review that we're doing. So I think probably a few important things to say. I think the level of funding that we've committed to reducing the waiting list pre the pandemic. So a lot of that money unfortunately wasn't able to be spent because of just where we were in terms of responding to the pandemic. But the level of funding that went in to reduce waiting times around autism, and then subsequent to that, the level that we've just committed to the provider around reducing the waiting times for children's autism is significant. We've never before agreed to put that level of additional funding in, and that's been based on the modelling around current demand, current capacity, expected demand as well. So I think in that respect, I think we've contributed quite significantly there as commissioners. The other thing, though, two other things I would say is specifically around autism. We're definitely not alone in this, and really that's hence why the national strategy's come out, and that's quite long awaited. We've been waiting for the national strategy for quite a long time now, and it really it is a problem around the rest of the country, so we're not alone. That doesn't make it any better. But the other thing I just wanted to say is the children's review that I reported on last time that Penny Harris is going to lead for us. So I've agreed that we'll do that jointly. So I will do that with Liz Davenport and Michelle Thomas now at Live Well, and that will be a jointly owned piece of work. We will all come back to governing body when we present that piece of work back, and what we'll be able to do through that is we'll have been able to talk to the providers to understand what some of the problems are around achieving some of those key quality metrics that are in the specification, and I think that will give us a really good idea if there's anything else we can do, whether that's about funding, whether that's about different pathways, whatever that's about. That will give us a good opportunity. So that should come back to us. I think it's due to come back to us in October at governing body, but it will have come through commission committee before then.
Thanks, Jim. I've got Gaynor and then Susie.
Yeah, thanks, Nick. Just to mention to Jo, if I could meet with her sort of off record, off this meeting, to talk to you about some work that was published by NHS England in Susan Rastrick's AHP long-term plan, and they had some really good innovative models that they published that SALT work had done, speech and language therapists had done in reducing waiting times for children. So I'd be happy to talk through that with you.
That would be fantastic, Gaynor. Thank you.
All right, thanks. And Susie, finally.
Yeah, I mean, just really quickly, I think Judy's suggestion is a really good one. So why don't we get the providers in and ask the question, how are we going to deliver the national strategy given the context in Devon, and try and have a sort of conversation in the round about all the different factors that might need to change in order to do this.
Yeah, and that is exactly what the review will pick up. So we will be doing that in conjunction with providers. So we'll be asking those questions. So Penny will be going into services, asking those questions of operational people on the ground, and then we'll come back here. And I know Liz and Michelle are keen to join me when we come back as well.
Okay, great. Right, let's move on then to primary care. Judy, you're on mute.
Yeah, sorry, nothing to add.
Okay, great, thank you. Any questions for Judy? No, and then we've got the commissioning committee. Nick Kennedy, are you reporting on that?
Yes, I am. Thanks, Nick. Take it as read. I don't have anything to add to the report either, unless there are any questions. Doesn't look like there are. Great. Okay, does anyone have any other business? No? Okay, thank you. In which case we can break for lunch. And would people be happy to start the private meeting at 1 o'clock rather than 12?